This is another lecture of the DAROGA series, and at this stage the topic is antenatal care. We now focus on the customized fundal height or growth charts, and we have a few examples how to manage a particular case. The overview. I first would like to summarize quickly 3 earlier DAROGA videos where we focus on how to measure the fundal height and how to detect and manage the suspected SGA fetus. Today's topic is how to manage particular case in combination with the fundal height, the growth charts. This gives us an opportunity to practice and to apply the acquired theoretical knowledge in day-to-day cases. And of course we will finish with a conclusion. First, for whom is this video? In particular, it's for all antenatal care providers working in antenatal care clinics where the customized GROW chart is used as best practice. This is also for the interested medical and midwifery students who want to know more about the practicalities of the customized GROW charts. This topic is not yet examinable because not all hospitals in South Australia have introduced the customized chart as yet. First, I would like to acknowledge Professor Jason Cardosi, who is in charge of the Perinatal Institute in Birmingham in the United Kingdom, because our guideline and our management is based on his and the Perinatal Institute's research findings and their guideline. Okay, introduction. Let's go back. In the video shown here, we presented a number of clinical skills, and important for this topic today is that every practitioner knows exactly how to measure the fundal height in a standardized way, because that means we reduce the inter-observer variation, as we call it. So between different practitioners we have a minimal difference in measurement. The second topic discussed already, we looked at different methods to detect SGA, their sensitivity, how good they were to detect the small for gestation baby, and eventually, what's most important of course, what impact it would have on the intrauterine fetal death rates. Interesting, just recently in December 2015, in the Lancet a study was published from the so-called POP study was published, and in their control group, by the way, in Cambridge, where the vast majority of the women were white, 93%, and also more than half of the women had a normal BMI, which is different from our population. Their control group had a disappointing SGA detection rate of just 20%. So that means still today, the customized fundal height chart is the best clinical available method. Whilst not perfect, that has to be acknowledged. This is the link for this second video. And in the third lecture we discussed how to detect and manage the suspected SGA fetus. We discussed in detail our GROW guideline, and here you see the link. This is a one-page summary of the guideline, where in brief we start measuring the fundal height after 24 weeks. We plot it on the customized chart. Is the first plot less than the 10th centile, or is the slope of various plots in a row less than the expected one, so the slope is less than the expected one, then the action should be request an ultrasound scan fetal growth within 2 days. And the ultrasound scan there's 2 options. The estimate of fetal weight as by ultrasound scan is more than the 10th centile, so that refutes our suspicion for SGA if the AFI and the umbilical artery Doppler are normal. Or the second option is that the ultrasound scan shows an estimated weight of less than the 10th centile or equal to the 10th centile. This will discriminate between the most likely normally grown baby and the baby who is SGA and potentially at risk. So that discriminates beautifully between green and red. Okay, today's lecture is from theory to practice. I have collated a number of cases so you can practice and familiarize yourself with how to manage a specific pregnant woman and her growth chart. Remember from the studies by Jason Cardosi in England that well-trained clinicians who adhere to the guideline contribute to a persistent lowering of the intrauterine fetal death rate due to missed IGR. And this is what this method is all about, avoiding a stillborn baby to be born. All 4 videos, including this one, all these lectures are mandatory for staff members of the Northern Adelaide Local Health Network in Adelaide, South Australia, everybody who provides antenatal care, so the doctors, the midwives, and including the shared care GPs. Let's commence. The first case is a 35-year-old healthy primary gravida. She is 28 weeks and 5 days and her BMI is normal. She reports feeling the fetal movements normally and her blood pressure is fine. You measure a fundal height of 25.5 centimeters. How would you manage this situation? Here we see the fundal height chart, so the first plot is well below the 10th centile. What should our first step be? First, we should check the dates, find out if the expected date of delivery is indeed correct, or sometimes an error has been made. If that's not the case, what is the next step? We check the biometry at the 19 to 20 weeks morphology or anomaly or anatomy scan, as it's called in various parts of the world. And why do we do that? We want to find out at what percentile the fetus was at the 19-week scan. You could argue that is probably representing the fetal, it's the specific growth profile potential of this particular baby. Were any abnormalities seen? And if not, then we request an urgent ultrasound scan fetal growth as per guideline. We need to exclude early SGA/IUGR. And don't forget, of course, this mother, the mother-to-be, had no signs of preeclampsia, so it's important to take the full clinical picture into consideration. By the way, allow me to make a little sidestep. If you find early symmetrical growth restriction, so in the first or in the early second trimester, that usually points at a problem with the fetus, either congenital malformations, chromosomal abnormality, or well-known are intrauterine infections. This is what we don't detect with the current guideline. Our guideline focuses on detection of the growth restrictions due to placental causes. So early growth restriction is very unlikely to be related to placenta-related growth restriction. What we see, the growth restrictions we see typically are seen in the 3rd trimester. I will show a few more details about that later. Apparently the placenta is no longer able to provide the growing fetus with the increasing demands of nutrients and oxygen. Here is where the intrauterine fetal death can occur and the IGR, due to IGR, if not detected. I think this is a very important slide to take on board. A study done in Melbourne and published in 2007. It shows on the x-axis we see the gestational age in weeks, up to 42, and on the y-axis we see the stillbirth rate per 1,000 deliveries. In black, the adequate, and the squares, the adequate for gestational age fetuses, and we see a slight increase after 39 weeks. Here behind is the large for gestational age fetus, and most importantly for us, we see the small for gestational fetus. The stillbirth rate is higher than the adequate for gestational age fetus, but we see enormous increase after 40 weeks. Here at this stage, the stillbirth rate is roughly 4 times that of an AGA fetus. So important to take on board that what we are particularly focusing on is the growth restriction in the 3rd trimester. That's what we focus on. Another case, case 1 continued. We have seen now an ultrasound scan, estimated fetal weight, depicted by the open circle here, and our second measurement of the fundal height is seen here. So the question is, how would you manage this particular case? Well, my ultrasound scan was reassuring, assuming that AVI and Dopplers were normal, so we continue to plot the fundal height. And as you see here, the next fundal height measurement shows a normal slope, so this means we continue to plot the fundal height as per protocol. What is also good here in this particular case, there were no risk factors for IGR, no symptoms of preeclampsia, so the clinical signs and symptoms, the ultrasound scan, were all reassuring. Hence, we keep on plotting. Case 2. You see now in your antenatal clinic a pregnant lady. She's healthy, Gr3 P2, after her initial visit, her triage visit. Her first pregnancy was uneventful. She had a normal vaginal delivery at 40 weeks and 1 day, and a baby boy was born with good EPGAR scores and a birth weight of 2.9 kilos. How would you monitor her fetal growth? Well, this is a bit of a curly question. Sorry for the Australian vernacular here. Your intuition, most of us would say 2.9 kilos, close to 3 kilos, that's about right. So we tend not to worry. However, we need more information, specific information about the mother. What was her ethnicity and her BMI? Because that gives us an answer to this somewhat curly question. Let's assume that this lady was an Indian lady with a normal BMI of 20.8. Then we see here the customized chart, and it shows clearly that her first baby of 2.9 kilos was the 36th percentile, so was absolutely normal range, adequate for gestational age or appropriate for gestational age. If we now move to another ethnicity, let's say we have here a happy European lady who is listening with a stethoscope to her baby, interesting, and her BMI is always as well within the normal range. Now the customized chart showed that her first baby, 2.9 kilos at 40 weeks, was on the 4th percentile, so small for gestational age. So the same birth weight, and thanks to the customization, we get a very good clue that we should manage them differently, and that our surveillance for the growth restriction for the SGA baby should be different. So our level of alertness and management is completely different. So for the first lady, the Indian lady, we just refer to routine fundal height measurement and plotting. However, for the Caucasian lady, it's appropriate to include ultrasound scans in the 3rd trimester. Serial ultrasound scan, roughly, for instance, 31, 34 and 37 weeks. And of course, in the second example, we would need to check whether there are any modifiable parameters which could influence the growth of the baby, such as smoking and lifestyle. So always consider the total clinical picture. It's an open door, but it needs to be confirmed once more. Does this lady in the course of the pregnancy have signs or symptoms of recurrent antepartum hemorrhage? Did we find a single umbilical artery at the morphology scan, the anomaly scan or anatomy scan? Are the signs or symptoms of preeclampsia, etc.? We as clinicians, doctors and midwives are never supposed to be blind Freddies. Case 3 continued. You see this Indian lady again on the 1st of February, and her estimated date of confinement or estimated date of delivery is the 19th of April. That was confirmed by a dating ultrasound scan. You measure now a fundal height of 26.5 centimeters. How would you manage her? Look carefully at the fundal height chart. As per protocol, you might be inclined to request an ultrasound scan fetal growth. However, the expected date on the chart is different from the one we showed before. So here it infers that her expected date of delivery would be the 12th and not the 19th of April. So the chart is not correct. So if we correct for the due date, the measurement is above the 10th centile, so no reason to request an ultrasound scan fetal growth. Sorry, there's a little bit of a pedantic case, but it happens in daily practice. That's why I would like you to know. So make sure the expected date of delivery on the growth chart is correct. Hakuna Matata, no worries. Conclusion, check after the first semester ultrasound scan, that is in most often the nuclear translucency scan, to contribute to the calculation of trisomia 21 and 18 risk, if the expected date of delivery is correct and consistent with the growth chart. I can refer to the dedicated lecture about calculation of the expected date of delivery, a 20-minute video, and here you see the link. If the due date is not correct, as we saw in this example, what would you do? There are two options. One is maybe to remove the calendar part of the chart, which just is a matter of using your scissors, a small, not too invasive procedure. You could argue that's the pragmatic or maybe a slightly lazy approach. Of course, ideally you should generate a new growth chart. It takes only a minute and a half. So if you're really an angel, and you should be, the second option is the best one, the preferred option. Let's now move to case 4. Gr3 P2, first baby boy was the 40th percentile. She presents at 27 weeks and 5 days, and you measure a fundal height of 28.5 centimeters. How would you manage? Another sneaky one. Intuitively, a lot of less experienced clinicians request an ultrasound scan fetal growth. However, we need to remember that the X represents the fundal height, not the baby. We measure the fundal height, so the uterus, the amniotic fluid, the placenta, the subcutaneous tissue, and below all that, the baby. So we are not plotting the estimated fetal weight, so this should not trigger requesting an ultrasound scan fetal growth. And compare, it's different from the first measurement below the 10th centile. If, however, we see now the same lady at 33 weeks and we have now serial plots 4 times, how would you manage this particular situation? Well, it's obvious that the slope of the fundal height chart is more than expected one. That means we should request an ultrasound scan fetal growth, because this raises the suspicion for a large for gestational age baby. The ultrasound scan should be regarded as the antenatal diagnostic test. Here is the ultrasound scan. The ultrasound scan estimated fetal weight plots well above the 90th centile. So per definition, this baby is large for gestational age. How would you manage that situation? Well, it depends in what clinic, what hospital, what part of the world you work, but most of us would, based on a big randomized clinical trial, and you see here a beautiful mind map of this trial, where it shows that in this scenario, in the fetus, the baby is better off when we induce labor rather than waiting. Good. Of course, in this scenario, we check extra how our oral glucose tolerance test was at 26 to 27 weeks, because it could point at gestational diabetes. Another case, a Gr3 P2. This is a routine antenatal visit. She's normotensive, and you find a fetal heart rate of 146 beats per minute. What fetal growth surveillance would you like to suggest for this lady? Have a look. Both her first and her second baby were appropriate, adequate for gestational age, AGA, hence there's no obvious risk factors for SGA or IGR. She had a perfect, what I would call, obstetrical performance, and hence we would do serial fundal height measurement and plotting as per protocol. Now we see another lady, Marie, Gr3 P2, And what fetal growth surveillance would you recommend for her? Her first baby, Louisa, was below the 10th centile, was even severely SGA, second percentile, hence serial ultrasound scan, estimated fetal weight, and particularly in the third trimester is warranted. Remember, the serial fundal height plotting is the surveillance test for low-risk women. This is an example of estimated fetal weight smash bang 3 times in a row on the 50th percentile. We have now a para 1, Yu Yang. She is from Chinese descent and her first baby was 2.8 kilos at 38 weeks, which was the 15th percentile, 1-5. Look at the fundal height chart and the trend. Yes, well done. The last two measurements, combining the two, the trend is less than the expected one, so we would request an ultrasound scan fetal growth. Here is your ultrasound scan. The ultrasound scan is on the 30th percentile, AFI and Douglas were normal, so we resume to measure the fundal height and keep on plotting. Now we see Yu Yang a few weeks later at 38 weeks, and the fundal height slope again is less than expected. We go back, we have now two options. Do you realize this is a para 1 at term? So if you have the opportunity to do a quick ultrasound scan combined with the CTG to confirm fetal well-being, that could be an option. However, if the ultrasound scan would take a bit longer, or if you look at the gestational age and the fact that she's para 1, induction of labor would be an attractive option as well. Even more so if the cervix would be favorable. Be aware, the vast majority of intrauterine fetal death and stillborn babies are due to missed IGR, especially in the third trimester. Hence the suggestion to induce labor. I trust you have learned a couple of useful lectures, and I would like to conclude. Congratulations, well done. Now you know how to measure the fundal height in a standardized way, when to start measuring and plotting the fundal height from 27 weeks onwards, but also you know when to request an ultrasound scan fetal growth. That's basically when the first plot is below the 10th centile or when the trend is less than the expected one. And of course we include, apart from the estimated fetal weight, the amniotic fluid index and the umbilical artery Doppler in the total picture. Now that means you are entitled to provide antenatal care and support our team detecting and managing the SGA fetus competently. Thank you so much. And this adequate for gestational age fetus thanks you as well. This concludes the fourth video, Antenatal Care, Customized Fundal Height GROW chart, and the 4 should be viewed as one package. Thank you once more.